with Mike Neville from the Institute of General Practice Management. What I would say to you all is please do share this meeting with your peers across the system. We seem to have lost a number of attendees as we've gone along. There's some great opportunities to kind of hear what's happening and kind of expand some learning. So I think it's really hopefully a worthwhile hour and a bit of your time. And we'll promote at the end of this session what's happening in September, because we will take a break in August, but the September session is really, really exciting. So hopefully Mike is with us today. That's hi Mike, that's who your forum is brought to you by. And so I'm Kerry Porter, Primary Care Workforce Programme Manager, and GP Excellence are kind of very strongly supporting this programme as well. So we're very grateful for their support. So we're going to start off with our GPM, and as you can see, we've got a lot of other really interesting speakers today, so we hope you'll find it beneficial. As usual, please do give us feedback, put any comments you have in the chat, we will be happy to respond to that. So I'm going to stop sharing my slides, I'm going to hand over to Mike, and I'm going to put myself on mute.
Yeah, thanks very much. I look forward to being the preamble to the actual good speakers today. So just a bit of background, I'm Mike Neville, I'm managing partner at the Neville Family Medical Centre in Blakely, North Manchester. I also run 2 other GP contracts at Cheetham Hill and Queen's Medical Centres, also North Manchester. LMC rep and also IGPM North West England representative as well. And I'm here to talk about the accreditation framework today. I've only been given 5 minutes, so I apologise for wasting it on terms of all the stuff that I do, rather than stuff that I'm here to talk about. But it's been a long time coming in terms of the accreditation for practice managers, and we're really excited to be able to sort of get this out there now in terms of what you can actually do and why it's important. The framework itself has been developed by our directors, one of which, Robin Clark, is a HR specialist by trade, as well as James Kingsland, who was also originally responsible for the AMSTAR programs, as well as a couple of other very highly qualified individuals. There's 10 domains, and I think the one thing that I wanted to make sure that everybody's aware of is when you're talking about the 10 domains themselves, it might be quite scary when you sort of see them. I was certainly scared a little bit myself in terms of what actually is involved, but the more that I actually went through the form itself, the application form, the more I actually just realized how much we actually do as practice managers or managers within practice management, within general practice. I've put a link in the chat there in terms of how to get the downloaded version from the site, which gives you the full information. But the main thing that we want to really make sure that everybody's aware of is in terms of that it's now fully live, and we've already seen a very, very positive effect, not only in a sort of wider primary care field, but also from a CQC assessment that one of our accredited managers down south actually had. So in the areas of good practice, it was noted that in terms of innovations, the fact that the practice manager had been accredited, and it really did show to the individual CQC assessor in terms of what level that they have been trained to, and also had experience within as well in terms of forming that leadership within the organisation. And I think at this moment in time, we're just really keen to make sure that it's known as wide as possible, the fact that it's there, what it is, how people can do it, which is obviously why I've sort of put the link in chat there. There's going to the next 2 deadline dates for submission for this financial year, for example, are 31st of August and the 30th of November. And in those windows, the accreditation assessments will be done within September and December. So we've obviously got a really good sort of line coming up there in terms of how often we're actually scheduling them to be 3 times a year at the moment, if not 4 moving on, depending on how many people are actually becoming and applying for accreditation as well. So I didn't want to take too much about this because there are other people who have previously spoken great length, and that's why I just put the link in the chat there. But if anybody has any immediate questions, I think Kerry has my details up on the screen on a slide. So I'm more than happy to either receive direct contact from anybody and everybody, or if you wanted to do it via the IGPM website as well, then there's links in terms of how to get in contact with your regional reps. So if you do have any immediate questions, I think I've got about 2 minutes left. So anybody who knows me is amazed probably at the fact that I've actually kept it that short and succinct. But yeah, happy to ask any sort of questions that, or rather answer any questions that anybody might have before my time runs out.
Thanks, Mike. I don't think there are any questions, but hopefully with the next segment there might be something that comes up. So if you're available to stay online, that'd be great.
Absolutely. Okay,
so I'm going to hand over to GP Excellence.
Hi, Kerry, thanks. For those of you who don't know me, I'm Lorna Laughlin. I'm the Practice Manager Advisor with GP Excellence. And the GP Excellence team have been meeting with Kay and Mike from the IGPM, and we've come up with an offer that we want to share with you today. We're going to offer 50 practice managers across GM the opportunity to go through the accreditation process and be fully funded for that by GP Excellence. We'd like practice managers who are interested in going through the process ready to submit an application for either of the dates Mike mentioned. So that's the 31st of August or the 30th of November. And as part of the offer, those practice managers, but also any other practice manager who or manager within a practice who is looking to have some additional support to go through that accreditation process, will be able to join us for a series of action learning sets or a peer support networking session covering all the different competency areas. And we're hoping that we're going to be supported by the IGPM directors. I know Mike and Kay are keen to support us with this. So the practice managers who will be working with us on those sessions and delivering those sessions for us will be practice managers that have gone through the accreditation process. So, you know, we'll be able to support you through that and hopefully make that application a little bit less scary, as Mike mentioned earlier. So if you're interested, I'm not sure how we're going to collect interest yet, but I'm sure you'll be getting an email out about that. But yes, we are going to give 50 managers across GM the opportunity to do this, and we really hope that you're all keen to go through this with us. Oh, just to say, we're going to deliver the sessions remotely. They'll either be a drop-in on either a weekly or a fortnightly basis. And as I said, they'll be facilitated by the IGPM directors and some members of the GP Excellence team who may have some special, experience in that field and are able to help you with that. Does anyone have any questions?
You've got a couple in the chat. So there's one saying, can they send aspiring practice managers?
I think that's probably one for me, and I think the other one's for you, Lorna, and obviously from the excellence point of view. The aspiring PMs, that part of the criteria that's in the link there is that people have had to have been in a management role within practice for at least 2 years. There was apparently there was a lot of deliberation around that when the accreditation team were going through that, but ultimately what they felt is that it gives you enough time to give the relevant experience to be able to sort of amount to the amount of time, amount of experience rather that the accreditation is actually required of. If I sort of waffled on that one, but ultimately it's 2 years experience is needed beforehand.
And yeah, I think the other one was probably for me. So Lindsay, what I would say is wait for the information to come out, and then just get in contact with us. We're going to have a look at the practice manager that we can support. We're hoping that we're going to do that as a fair share ratio over GM. So, but by all means, put something in retrospectively to us if you've already been proactive in signing up for it. And Catherine, I realised as I was talking to you about this, I didn't know the answer to that. So as soon as this meeting is finished, I'll speak to Rose and we'll make sure that we get something out to you as soon as possible. In the meantime, I think our information is in there, and we'll start to gather information from you. I don't know that it'll be a first come first serve, but we'll certainly be looking to get this offer of support up and running very quickly, because we're aware that that first deadline is looming.
Okay, a couple of others I've noticed, probably more for me. It's not specifically for a practice manager, so it is within any person who's within a management role within general practice, and that includes PCNs as well. So that it really is open. So I mean, just going through, there is a sort of list of overall job titles, but it's more creating the experience within your job title. So practice manager, business manager, ops manager, assistant deputy practice manager, manager of a specific function with a higher level of accountability, so finance manager, HR manager in the very, very large practices there, or PCNs, or managing in a scaled model incorporating general practices, so GP feds, primary care networks. The question relating to CCG work, I've got to be honest, I don't actually know 100%. So it's definitely a question I'll go back and find out for you. But from what I understand, it's specifically within general practice management, but I will get that verified for you.
So I think the chat is really, really good, interesting, rich information, isn't it, that hopefully will help inform the comms when it comes out. So certainly kind of what the criteria is, and when we can expect the comms. So I think, thank you everybody for that. That's really helpful, and I'm sure GP Excellence will then shape their comms around the feedback that you've given here.
Yeah, Kerry, just say we've actually got a couple of polls, if that's okay, just as a part of Lorna's sort of segment here, and also just to say we're hoping to get some comms out either tomorrow actually or early next week. So yeah, look out for that email from GPX, and it will have all of the information you need, and then you can also get in touch if you have any further questions at all. So if we just quickly launch those polls now. It's just to get your general interest after hearing that little segment from Lorna there about our offer. So the first one is, would you be interested in completing the IGPM accreditation process with the support from us at GP Excellence? Following from what you've just heard, so just launch that one quickly. Should be going.
Mike, do you want to answer the question while Rose is kind of loading that polls around how much the course costs?
Sure. So I was actually just going to reply in the chat, but I've got a bit of airtime. Yeah. So in terms of the expressions of interest themselves, no, not at all. Everybody's free to do it at will. As I said, all the information is actually on the IGPM website, which I can re-put in the chat just in case everybody doesn't have access to it for any reason. So no, you can basically just do it whenever you want. And I think there was somebody also mentioned earlier on that they've already going through the accreditation document and had a question about whether it's going to be reimbursed or not. It was a Lindsay Philbin there from Ribsdale. So that's a question more for Laura, I think, wasn't it? But in terms of the costs themselves, as with any professional accreditation, there is obviously a cost involved. In order to submit your accreditation application, it's £280, and if you don't, I suppose, pass the accreditation the first time round, any sort of resubmission, which would only be changes to specific areas, specific domains rather, then the resubmission is 120. So the costs involved, as I said, it's the membership to be part of the IGPM is £50 a year, and that's on an annual recurrent basis. One of my practice managers recently in North asked, I've actually been a member now for more than 12 months, but I've not had a re-membership notification, but I think that came out today, or it certainly did to me anyway. So it's an annual £50, but in terms of the accreditation itself specifically, as I said, it's £280, and any sort of resubmissions would be 120. There's a question as well in terms of whether the places for the less than 2 years experience. I think there's a bit of a crossover in terms of the different things that are going on here. So the accreditation process itself, the criteria to submit is to have the experience of 2 years. So there is unlimited numbers of places there is in terms of people who want to apply for accreditation. That it's just GP Excellence have managed to get the funding to actually do that for 50 people from that pathway.
Just to say on the 50 that we will support, it will be 50 people that meet the criteria for being able to go through the accreditation at the moment.
And also time on average, that's an interesting one. It does take time. I think, to be honest, when I was filling it through though, it only took so much time because I sort of ran away with myself in realizing how much I'd actually done in my roles and how relevant it was and how things kept on popping into my head, especially if you were, especially if you looked at how similar certain sections are in terms of how they interlink as well sometimes. So what the one piece of advice I'd give there is, if you just because you've mentioned it in one section, just mention it again in another section, because as I said, it's all done based on the score you get in each section and then averaged over the whole amount of the accreditation document itself. So you may just because you've mentioned it once in one area doesn't mean it's not relevant for another area as well. But I think it took me, I'd say, dipping in here and there, maybe about 3 hours to. But again, as I said, that's because things kept on popping into my head. I reread it through, proofread it, and make sure I didn't sound like an idiot, or more so than I am doing today. So,
thanks, Mike. Rose, do you want to launch the polls?
Sorry, it's not working. I've just tried, and it just keeps loading. My internet's connecting and disconnecting. I'm sorry about that. It was if we just move on to the next section. Sorry, Kerry.
No problem at all. Actually, I was just going to say, I have sent you the slides because I've been kicked out twice.
Oh gosh.
There is an issue with Teams today, I know.
Yeah.
So I will share. Leslie Royal Prior joined us, who's the primary and community nurse lead, and she's going to talk to us about fitness to practice with our general practice nurses. So if I do pop off, Rose, hopefully you'll be in the background, won't you, to save the day.
Yeah, no
and
worries.
We can try with the polls.
Yes.
Okay. Over to you, Leslie.
Thanks, Kerry. I believe I'm next. Sarah's got a hand up because I think on your agenda, Sarah is next.
Yeah, sorry,
actually.
I do have to go.
And she'll
3,
have to
so.
go. Yeah.
Is that all right?
I'm so sorry, Sarah. That's me.
That's fine.
I've skipped my agenda. Apologies.
No.
Over to you.
Don't worry, let me just share my slide and get my hand down. I'm also having Teams issues today, so I do apologise if I disappear at any point. Right.
Oh, I don't know if we've lost Sarah. Frozen.
Can you hear me now?
Oh, yeah, you're back.
Yeah. Okay, sorry.
Thank you.
So I'm just going to try and boost my Wi-Fi whilst I'm doing it. So firstly, I just wanted to share with you the uptake in the cervical screening programme. This is Greater Manchester wide. So you can see the kind of pink colour is 2019 from December, and then you've got 2020 and then 21. So obviously we'd expect that dip in 2020 due to the lockdowns and a lot of face-to-face appointments stopped. But as you can see, kind of during 21, that hasn't really recovered very much for various reasons. Still pressures in primary care, women not wanting to attend. You can see your practice level data on this link, which I can share, and you can compare to other practices within your CCG or locality, and also across the country. So I'll put that in the chat. And similarly for the 50 to 64 cohort, where uptake is a bit better, but it's still seeing that kind of declining trend across all areas. So as you may be aware, the turnaround time at the lab for results is currently around 49 days. It does fluctuate at the moment due to various factors. The sample taker database should have the most up-to-date data on it. A lot of results are coming back much quicker than this, but depending on who needs to review the slides, some of them are taking a little bit longer. So people in the practice should be aware of this. I'm aware if people are ringing chasing results that it could take up to 7 weeks for them to come back. But please make sure that if you are following up results, that reception staff don't give the lab's number out because they're not able to advise patients on their results. The practice are welcome to ring the lab to chase, but they won't deal with patient queries. I'll talk about fail-safes later, but if after that 7-week time your fail-safe shows that a result hasn't come back, then you can contact the lab. It may be that the result didn't get there in the first place, or it may have been rejected, which we'll also come on to. So all sample takers should be using electronic requesting via ICE or through the ICE desktop or the Intraop. The vast majority of sample takers are using this in primary care, which is brilliant. So thanks very much for all your work getting that set up. If you do have locum nurses or GPs who maybe don't take samples very often, ideally they should be using it as well. And you can request access for them by contacting the lab, and the details are on there. HMR 101 forms can also be downloaded from Open Exeter if ICE isn't set up, and paper request forms really shouldn't be used unless there is an IT failure, whereby none of the alternatives can be used. Rejected samples, which I mentioned earlier. So you may be aware that there's quite strict criteria of who's eligible for cervical screening, and that the forms all have to be completed correctly, and any that fall out of these criteria will be rejected by the lab. When that happens, the practice is sent a letter informing them of the patient details and the reasons why. So in the last 12 months, we've had over 1,000 rejected samples in primary care, which, when you add up all the time for contacting those patients and offering them a repeat appointment, it adds up to quite a lot of time for yourselves. So we're really trying to work with practices to reduce the number that get rejected in the first place. As you can see here, the majority of samples that are rejected are due to early repeats, which is that they're not due yet, or you can take a sample 3 months before it's due, but if it's earlier than that, then it will be rejected. And it's important sample takers have access to Open Exeter if they need to double check when they're due. It's an awful lot being taken in out-of-date vials, and we have worked with the lab to update their request forms, so that's now a mandatory field. But stock rotation is really important, and if there's like a room that you don't use very often, just making sure everything's in date within the practice. And then unlabeled vials or discrepancies between the form and the vial. Quite often we get one patient on the form, another patient on the vial, so maybe a child or another patient at the practice. So just little things, all these things are quite avoidable, and things can be put into place to avoid them from happening. So this is what we recommend for practices to put into place. We have shared this previously. We've got a poster for it, and we can share that again. And we are in the process of filming a video for sample takers, just to go through kind of a best practice walkthrough of how to avoid samples being rejected. So hopefully you'll be all familiar with the cervical screening sample taker database, which is run by the lab. So this is where you have all your sample takers registered with evidence of their update training. They've just completed, at the moment, they're carrying out an audit of all the training certificates on the system. So hopefully, if there was any discrepancies in any of your sample takers, they'll have been in contact with you and asked you to make sure that the up-to-date training is on there. So sample takers need to have 3 yearly updates, which should be a minimum of 3 hours. So there's an e-learning for health module. I've put an example certificate here, which is the best one to use at the moment. There are other private providers offering training, but quite often they don't meet the criteria of what needs to be included, or they're not long enough. So if you are unsure of whether training meets the requirements, do get in touch with us, and we can help you with that. And sample takers who've been away from practice for over 12 months should be completing a period of supervised practice, which is really important. And that's all detailed in the education pathway, which is linked there. Please make sure you're familiar with what certificates are required. So on the eLearning for Health, there are a number of other modules for cervical screening, such as the HPV primary update. While sample takers do need to do that, that doesn't constitute as their 3-yearly update. That's like an additional module. So to make sure your sample takers are up to date, that's the training. Are working with the training centre at the moment to see if we can start offering face-to-face update training again, because a lot of people have been requesting that. So we'll be in touch when we've got further information. So all sample takers within the guidance should have a fail-safe to make sure that there's been a result returned for every sample that they've taken. So that could be that the sample taker keeps their own list of samples that they've taken, just to make sure that the results back. Or it could be that the practice have a practice level search, that after so many weeks, you do a search to see, for instance, how many people had a test more than 6 weeks ago and how many are missing results. So this is to make sure that that any samples that were taken made it to the lab in the first place, because we have had incidents where they've gone missing in transit, or they've been accidentally put in the wrong place and they've ended up in a bin, and all sorts of different incidents. But also, if the sample was rejected and the letter wasn't actioned, then it's an extra opportunity to make sure that that's picked up and that the woman's contacted and rebooked in. So for a sample's been rejected, then the practice should have a system to recall them in 3 calendar months, or if it was an early repeat, when it's due, but it should be taken no less than 3 calendar months after a sample's rejected. Important that the onus isn't put on the patient for them to chase their own results. The guidance is clear that the sample taker should have that fail-safe. We have had an incident recently where a fail-safe wasn't in place and the woman wasn't contacted. And then she wasn't followed up for a number of years, which has ended up in an incident. And this is just from the national guidance, which just highlights the responsibility of the sample takers to make sure that that fail-safe is in place. So we're aware of quite a few PCNs who want to deliver cervical screening across their PCN network, which is great, and we really do encourage any things that that practices or PCNs want to put into place to try and increase their uptake and improve choice for women. If you are going to do this, or if you do want to set this up, or if you've started looking at it, please do get in contact with us, because we do have a specific SOP that's in place, which with the lab, it's just to make sure that the lab are aware that the samples are coming from somewhere that's not the patient's registered practice, in case there's any issues, any incidents, any samples rejected. We just need to make sure that you set up in the correct way. It's not very onerous, it doesn't take too long to get everything in place. So if you are thinking of doing a PCN clinic with patients from multiple practices, then do get in touch with us and we can help you get that all set up in place to kind of prevent against any potential incidents from occurring. And then I've just got a few general updates. So there is going to be a replacement to Open Exeter, which will be the cervical screening administration system that was supposed to launch last year, but it has been delayed. So although we know you don't really use Open Exeter for anything else at the moment, it is still running for cervical screening. So in terms of checking the prior notification lists, the PNLs, and to check patients' histories, sample takers should still have access to that, and the admin staff that are doing PNLs should have access to that. So please make sure that's in place, and we will be in touch when the new system is launched, which hopefully won't be too long now. You may be aware that there's some self-sampling evaluations and clinical trials happening across the country. So this is where women can take their own sample, which will test for the HPV virus. At the moment, it's not part of the national screening programme. It may be in the future once these trials have been completed and evaluated. But if anyone does purchase one privately, that can't be recorded as part of the screening programme. So they would still be eligible for their kind of normal cervical sample, and we would encourage them to take that up. And you may be aware as well that in Scotland and Wales, they've extended the screening interval for the younger cohort, the 25 to 49 cohort, to 5 years rather than 3 years. This will be coming in England, but we don't have a confirmed timeline for that yet. And again, we will be in touch with you when we know more. So that's my update. I think I've got a few minutes for any questions. So if you do have any queries, do please feel free to email any of us there, myself, my colleague Sarah, or our generic line, and one of us will be in touch. But if anyone has any questions now, I'm happy to try and answer them. Michelle?
Hi Sarah, can you hear me okay?
Yes.
Yeah, I'm business manager at Urban Village Medical Practice. We've done a lot of work around this over the past couple of months. We've basically process mapped the whole of the cytology process around when patients join, registration, GP to GP, PNLs, fail-safe, etc., because it's got so many different branches of it. It's huge, and it's not until you get all the people in the room and you map every part of that process you realise what you need to look at. I think the biggest thing for us that come up when we were looking at where things potentially went wrong, because there is gaps in our system even though we thought we were okay, is when the patient joins and we think that GP to GP is the most updated because it's been around for that long now. You would expect it to be that way, but when our admin staff then go on to open exit and the PNLs, it takes, and I don't know whether you're aware of this, it takes at least 6 weeks, if not more, for the ladies' details, the new patient details, to arrive in open Exeter, if you like. So that's a substantial gap if we're trying to get ladies in that are actually due.
Yeah.
So I think when we were looking at sort of the searches that EMIS have got, where we think we were up to with ourselves, that's when we started to see the gaps, because there is gaps there and you have to allow for them. So it was just that type of awareness, to be honest, because until, as I said, we'd done a 3-hour session on all of them different areas and what it materialised and things we needed to put in place. And it was even around sort of gaps around our coding, so if it wasn't on the ladies GP to GP around hysterectomies, etc. That all of them things exist, and that's where it can fall down within that whole process. So it was a very interesting, and it was worth the investment of the people in the room to go through that. And what it did highlight was the gaps in several different areas, because everyone, I don't know, tends to think that it's so easy that you do a call and recall for a lady, and there it is, you don't realise the intensity of what goes on to get it to that stage.
I think a lot of things are kind of passed down from person to person as people leave, and I think sometimes a lot of the little bits are missed or not passed on, and then it turns out to be just call someone and then do a smear and then that's it, when actually the pathway is huge and it's quite complex. So that sounds like a really useful piece of work. I'm not sure with the new system if that will update any quicker, but I will try and find that out for you. That's interesting to know.
Okay, and I'll make contact with you over the PCN, because we do Super Saturdays for our PCN, and we'll do more.
I think someone got in contact from your PCN about it. Yeah, possibly. Yeah. But yeah, do drop me an email and we can I can look at it for you.
Okay, fab. Thank you.
Great, thank you.
Sarah, there was a comment from Wendy regarding the replacement smear pots.
Yeah, so again, if you get in contact with us, I'm not sure if we've got any record of Stockport GPs doing it as a PCN clinic. So if we sort that out with the lab, if you get in contact with us, and then we can sort out the pots and where they need to go to, right? If it needs to go to a central point rather than the individual GPs.
Hi Sarah, it's Wendy. I'm not sure if you can hear me. I'm on a bad connection at home. That's why I put it in the chat. Yeah, that's great. I mean, I have had a number of very desperate conversations. So It is done in Stockport from about 7 different hub sites actually. So I'm not.
Is that like the extended access service?
Yes.
Yeah.
Yes.
Right. Yeah. No, I think that is. Yeah.
And obviously things are going to be changing from October, and it's certainly smears are really good on a Saturday, and we don't want to be losing that. So if anything, we're probably going to increase that take up. So a definite conversation. So is that we've got PCN managers, so if I get them to drop you an email?
Yeah, so the issue is currently that when if someone other than the GP practice takes a sample on the lab system, it looks like the GP practice took it, which is why we have to put the SOPs in place. So it's hard for them to know how many pots need to go to a practice versus a PCN site versus an extended access site. So it's something we're working on with them. So I'm happy if you drop me an email, we can look into it.
Yeah, because I'm quite nice because I'm one of the hub sites, so I tend to just throw everything in one pot and just use our stock, and then when it comes to our patients, we end up with nothing because it's been used in the hub. And I'm trying to get it back off other practice sites. It's just a complication.
And it's hard for the lab as well because they end up sending a lot of site pots to the practice, which the practice aren't using, so then they go out of date and then we get rejected samples. So it's a big problem.
Okay, that's brilliant. Thank you.
Someone's in the I'm not sure, Indra, about that. I'll try and find out for you about getting a list of patients by the recall status. Yeah, well, we'll try and find out and see if that's possible.
And there was actually 2 questions, which is around training for cytology.
So I will put the link to the training centre in the chat. NEPSEC deliver the initial training. I think Liverpool do it as well. Liverpool University, and NEPSEC's the one based in Manchester, for practice nurses or nursing associates as well. I'll put it all in there.
And we have got, I know I introduced Leslie a bit too prematurely, but Leslie is going to speak to us about fitness to practice in general practice nurses and the role of the nurse associate. So Leslie might want to pick up on that as well. Anybody got any other questions for Sarah?
Thank you, everyone.
Sorry, Sarah, will you be getting? Will we be getting the slides just with all your contact details and everything at the end of this? Yeah, brilliant. Thanks.
Thank you, Sarah. Okay, so I've introduced her once. I'm going to introduce her again. It's Leslie Royal-Pryor, Primary and Community Nurse Lead for Greater Manchester.
Thanks, Kerry. Hi again. Really quite a fitting start to my presentation from what Sarah said, really, around cervical cytology. And I just want to go back to one of the slides there and I know we're talking about processes and how we can make them better and swifter and more appropriate for our patients. But when you look at the figure for last year and say 1,000 samples were rejected, through all those different reasons why they were rejected, that's 1,000 women that didn't get a smear, 1,000 women that had to be asked to come back, and how many of that 1,000 came back for those smears? I know the screening team do have that information. I don't have it with me today, but if we relate those numbers to ladies getting their screening, I think that's a terrible number. So whatever we can do to reduce that would be great. So we'll go on to fitness to practice. So I'm going to give you just a brief overview of the current and soon to be changing process that the NMC are putting into place, what it is, what the reforms are and what they'll do, how the decisions on fitness to practice are made, what it means to the professional and the employer, what help is available for us, the NMC support and guidance and CQC support and guidance. You may already know this already, so it might just be a refresh for you. So if you can turn to the next slide, please, Kerry. So the NMC Code of Conduct is the professional standards that nurses, midwives and nursing associates must uphold in order to practice in the United Kingdom. And it's structured around 4 themes: prioritising people, practicing effectively, preserving safety and promoting professionalism and trust. and each nurse and midwife and nursing associate must make sure that their skills, knowledge, education and behaviour don't fall below these standards needed to deliver safe, effective and kind care. By meeting these standards, this is being called fit to practice. Next slide, please, Kerry. So what is fitness to practice? So when a concern is raised against someone on the NMC register, their skills, knowledge, education or behaviour, the NMC will go through a fitness to practice process. And that, like I said before, can be a registered nurse, a registered midwife, a nursing associate or a registered health visitor. Next slide, please, Kerry. So how does this work? So the process allows the NMC to understand as quickly as possible whether a registered professional presents a risk to the public. If they do, the NMC will take steps to promote learning and prevent issues arising again. The NMC will always take action if needed. That could include removing people from the register in the most serious of cases. But in the majority of cases, they feel that the best way to keep people safe is from learning from incidents and from stopping those incidents happening in the future. So when there is a risk, the NMC take into account the context in which the incident took place and any steps that that professional may have taken to strengthen their practice since the incident. And that's around reflection and whether or not they have realised that they've made that mistake and they can rectify that. So the NMC operate this process which allows people to tell them what happened straight away and encourages us all as professionals, members of the public and employers to engage with the NMC to make sure that they make the right decisions as soon as possible. Next slide, please, Kerry. So the NMC have a reform going on for the fitness to practice at the moment, and they are hoping that the current changes will be made to support earlier engagement with concerns, improve information prioritisation and being fair. So they're looking really at the people and the professionals like yourself, the employers that are involved in these processes, looking fairly and kindly and making sure that we are supporting people as well. Next slide, please, Kerry. So what they're after doing is making the right decisions at the earliest possible opportunity, and they're bringing case examiners into the decision making, and this is usually where so currently this is usually where there's a fitness to practice panel meeting, and if there isn't, the case examiner closes the case. So these case examiners have had 575 cases in the last 12 months, which is only 50% of the cases. And they've been extremely long investigations. So you can imagine there's lots of professionals, nursing professionals and employers that are stuck in the process, waiting for an outcome, don't know whether or not the person can continue practicing, and that person suffering quite a lot, that professional suffering quite a lot as to what the outcome of that process is going to be. So under these new reforms, the NMC are going to close the cases earlier, especially where there's no risk to the public, and as long as they have the right information. So they won't need to involve case examiners to make the right decision. Next slide, please, Kerry. Okay, so what does that mean for us? So that means there's less time, like I said, spent on the process and less stress. So that's stress for employer and for the professional. Better support, so we're asking that there's more evidence given forward in the first instance. There's less likelihood of long, lengthy hearings and long drawn out processes. There's fewer decision points and quicker outcomes for the person. And like I said in the beginning, better communication. So fitness to practice really is about managing the risk posed to the patient and the public in the future from that professional. And by providing the best protection possible by having decisions made swiftly and publishing the reasons openly. So what they're asking is employers to deal first with concerns unless the risk is so serious that the NMC needs to act immediately. So the caveat here really is that the NMC will also take regulatory action when the risk to the patients or public safety isn't effectively managed by the employer. And the NMC will take into account the context that the professional was practicing in when they made that decision. So, for example, they may not take regulatory action for a clinical mistake if there's no longer a risk to patient safety and the nurse, midwife or nursing associate has been open about what went wrong and can demonstrate their learning. However, what they do say is that deliberately covering up when things go wrong is serious and undermines patient safety and damages trust in the profession, and therefore they would pose restrictive regulatory action on that individual. In cases outside of clinical practice, taking action by the NMC is to maintain public confidence or uphold standards when that's needed, and concerns are raised usually around trustworthiness. Next slide, please, Kerry. So they've created some resources for you really alongside this. So there is an employer link service. This was created after the mid-staffs review, and it's one of the many contacts for the NMC. Our local contact is a lady called Paula Palmer Charlie, and the employer advice line is there for you to take down and use. I imagine these slides will be sent out. Is that right, Rose? That's great. So next slide, please, Kerry. So similar to what we've discussed earlier then, this is around managing the concerns. This is a new resource that the NMC have produced. You can click on that link there and it'll take you straight to it. It tells you best practice principles and questions for employers to consider when you start investigating and managing concerns locally around nursing, or whether or not you have got a situation that you want to investigate. It's about promoting a just culture approach and encourages health and social care professionals to speak up and learn from mistakes. And it's about it's giving you those case scenarios to illustrate when really to make a referral, and that's supporting the referral process. Next slide, please, Kerry. So this is a fitness to practice care line. So this is for any of your nursing staff who may be going through a fitness to practice hearing, or maybe in that process in some way, and it's a free and confidential emotional and practical support service, just so you have that number available to give out to somebody 365 days a year and 24 hours a day. Next slide, please. And this is the employer link service that's been set up. So there's an advice line here that you can call Monday to Friday, 9 to 5. If you've got any issues that you want to just review over, these are the things that you'll have to have in front of you to speak to somebody on the advice line, and they will advise you further. Next slide, please, Kerry. So like I said earlier, the NMC really are encouraging us to take local action first of all, to investigate and to look locally what can be done. So in that first instance, my suggestion to you, if this involves a nurse, a midwife, a health visitor, or a nursing associate in your practice, or this could be a agency nurse or a locum nurse that's come to work for you as well, because we can't keep them aside of the fitness to practice. They still are on the NMC register. This contact here are for our nurse leads locally, so our executive nurse leads of the old CCGs, so in your locality areas, and the primary care nurse leads, which will all be there to help you if you have a problem. Next slide, please, Kerry. That's it. The only other thing that I'd advise you to do is, and you probably know this, I'm probably teaching my granny to suck eggs, is that the NMC have a link you can go on and you can look up somebody's registration details. You can look up a nurse's registration details on the register. You can put the name in and where they're from, or you can put their PIN number in, and it will tell you straight away whether or not they have any restrictions on their practice or if they've re-registered. So it's always as wise to do when you take on new staff, or even have a locum nurse or an agency nurse coming in to work for you. Thank you. Any questions? I can't get my chat up here, so just.
There are no questions in the chat, actually. I have put the managing concerns link in there.
Yeah, thank you.
The slides will be shared, so you will have all this information coming out to you.
I imagine it's what everybody knows already, so it's just a refresh, isn't it, really? But it's handy to know who your local contacts are there if you do have any concerns, who you can contact for support, and that the NMC is always available. Thanks, Kerry. Do you want to go on to the next one?
Yes, so staying with Leslie, Leslie's going to talk to us in response to your feedback at previous practice managers meetings. You asked us there was some ambiguity between the roles that the nurse associate could do compared to a GPM. So Leslie's going to come and speak to you about that, but we just have some polls first, which hopefully I'm going to
will work.
Fingers crossed. Yeah. I'll give it a go.
Rose, do you want to? Yeah, let's. If you could contribute to this, I'm sure it will really help shape some of the work that Leslie's doing.
Okay, I'll just try and launch that first one. Hopefully, it will work. Fine.
Yeah.
Yes.
There you go. So the first one is: are you considering employing a nurse associate? Really simple. Yes, no.
Is that loading, Kerry? Can you see the answers coming through?
So I need to probably go in the chat, don't I? Because
oh yeah, it's coming through. I can see it on mine.
Okay, fab.
So yeah, so we've got 40% yes and 60% no at the moment. Okay.
Oh, I've got some errors that have appeared in my chat.
Oh gosh. Teams are testing us all today.
I know. So I think Michelle and Wendy and Jenny and Elaine and Kath have all contributed. But it comes up as a little error in my field. I really
Okay. That's okay. So I can sort of share the results. So what I can see, we've got 41% yes at the moment and 59% no. That's 29 responses. So that's that's what we've got at the moment. I can try launching the next one.
Yeah, please.
What is stopping you from employing a nurse associate? So I'll just launch that, and hopefully more people will be able to contribute to that. And that's just a free text one. Brilliant, they're coming through now. Hopefully you can see that. So we've got money in estates, no space, mentorship, extra nurses, funding, no time, TNA, additional member, current HCA, lack of knowledge, lots of things coming through there. Brilliant.
Rose, it's Mike. I just thought I'd clarify because I think you said bits of mine on about 3 different angles. Because basically we looked into this quite heavily, and what we'd actually prefer is to train our current HCAs up into the nursing associate role, rather than have number one, try and find rooms. I think of states obviously mentioned, but also the costs of an additional member of staff. So it's actually making sure that we can get the HCAs onto the specific courses, and it's making sure that they have things like evidence of their maths GCSE and other things like that they I suppose after a certain while everybody needs to then try and find. So those are the stumbling blocks that we've had so far.
Oh, thank you, Mike. Thanks. That's great. So we've got lots of different things there. Someone agreeing with you, Mike, in the chat as well. Well, and then just lastly, scroll down. Do you currently have a nursing associate or trainee nursing associate in place? So I'll just quickly launch that one. I'm getting error messages again on that one. I don't know about anybody else.
Yeah, so yeah, I was going to say, if you wanted to put kind of in the chat, we can make sure that it's then put into a poll. Yeah, there's lots of error messages. Teams is testing us. So
I've managed. We've got some responses from that one. So 31% yes and 69% no to that question. Thanks, everybody. I will just. Okay. Right, Leslie, do you want to? It was just those 3 questions, wasn't it? I think, and then we've got a couple after your session. Okay.
Thank you.
No worries.
No, thanks very much for that. Hopefully, I'll answer some of those questions that you've posed there, and we can speak about it afterwards. So, right. So, nursing associates in general practice. So, some of this might be new to you, some of it may be what you already know. So excuse me if I'm telling you what you already know about the nurse associate role. So the nursing associate is a new support role in England, just in England, not in Scotland or Wales. It bridges the gap between healthcare support workers and registered nurses to deliver hands-on person-centred care. A qualified nursing associate will work with people of all ages in a variety of settings. The role was introduced in response to the Shape of Caring review in 2015 to help build the capacity of the nursing workforce and to deliver high quality care. Next slide, please, Carrie. So what are nursing associates? So they're trained to foundation degree level. The qualified nursing associate, once trained, will not only bridge the role between healthcare support workers and registered nurses, but just like we've been saying previously, will also support the career progression for HCAs, enabling them actually to become registered nurses in the future. It also will support registered nurses in practice or in secondary care or in the community to focus on more complex clinical work. It will also increase the supply of nurses by providing, like we said before, a progressional route. Next slide, please, Kerry. So why employ a nursing associate? Well, it can improve service delivery and patient care because we're expanding a nursing team here and we are improving the quality of care that we're delivering to patients by having a nursing associate that is patient-centred, so they'll see more of the patient. It will improve staff retention. Obviously, we've said that before, through career progression. So like Matt was saying earlier, and somebody else commented in the chat, that, you know, you have a healthcare assistant who wants to progress, can see themselves becoming a nursing associate through training, through an apprenticeship route, and on towards registered nursing. There's actually no stopping them once they get going, and we've seen that in quite a few cases. It really is, again, grow your own. So grow your own nursing workforce. It really is a really good starting point. For a lot of healthcare support workers, not only younger ones, but older ones that have possibly not had that opportunity previously to take up university training to become a nurse through whatever reason, through personal reasons, or just maybe through entering the profession, the caring profession late on. But it really is a fantastic opportunity to grow your own nursing workforce. And also the training is accredited by the NMC. So, you know, and they're once qualified, they are registered with the NMC as well. So 4 good reasons there for you to employ a nursing associate. So next slide, please, Kerry. So the big question is, what's the difference? So the NMC have come up with this infographic really to show you just what the differences are there. And as you can see, if you can actually see that, there are 6 platforms to the nursing associate role and 7 to the registered nurse. And the differences are not, the similarities are that they are both accountable professionals. They are both promoting health and preventing ill health. Where the registered nurse is providing and evaluating the care, the nursing associate is providing and monitoring the care. So the difference there is evaluation. Where the registered nurse is leading and managing nursing care when working in teams, the nursing associate is just working within that team. They're both improving safety and quality of care, obviously. But however, the registered nurse coordinates the care and the nursing associate contributes to integrated care. And that 7th platform for the registered nurse is assessing needs and planning care. So the nursing associate does not assess needs or plan care. So hopefully that makes things a little easier for you to see between nursing associate and registered nurse. Next slide, please. Okay, so benefits to general practice. So what can they do? So they can manage, assess and monitor patients with long-term conditions. We've just said they can do the monitoring. They can carry out reviews with patients who have long-term conditions, and that's with that registered nurse having oversight and planning the care and evaluating the care. They can do health checks, vaccinations, immunisations, B12 injections. They can be a lead for infection control. They can do complex dressings with the oversight of a registered nurse, wound care and removing stitches. The chat said before, where can we get training for cervical cytology? And yes, now they are able to do cervical cytology. One of the other roles that they can do is learning disability health checks, and they do improve service delivery. They do. So there are some great benefits to introducing a nursing associate into a nursing team. Next slide, please. So hopefully, I don't know whether you can see this. So this here gives a view of task and skills between healthcare assistant, nurse associate and practice nurse. If you have a look down those lines, you'll see what a healthcare assistant can't do and what your nurse associate would be able to do. So there's not much difference there between your nurse and your nursing associate, other than your practice nurse leads, manages, supports, works autonomously, and is the decision maker, supervisor, and reviews and delegates. And you can see where that nurse associate fits into that team. A nice one to just point out there is the medication administration, and this will cover us in general practice for immunisations. As you can see, it excludes the nursing associate from PGDs. They are not able to give immunisations from PGDs. So although they are on the NMC register, they are not a registered health professional according to PGDs, and would actually have to use a PSD in practice. So you can see there that they can be a mentor for new nurses and for new healthcare assistants. So, you know, they can support new trainees into practice as well. And they can do most of the things that your nurse could do. So freeing up your practice nurses to more complex patients and to take on more complex roles. Next slide, please, Kerry. So the NMC here have given the standards of proficiency for nursing associates, and this just outlines the standards of knowledge and skills that a nursing associate needs to meet to be considered by the NMC as capable of safe and effective nursing associate practice. For us, this provides clarity on knowledge and skills and allows and informs us on safe decision making on delegation. So it's really worth a read. Next slide, please. I think that might be it, actually. Oh, yeah. Any questions?
Do we want to?
Do you want me to just say what we're doing?
The last two polls.
Oh, yeah, go on then. Yeah,
yeah, that'd be really helpful, Leslie, because especially with the questions before about how do people access cytology.
Yeah. So we're currently developing a nurse associate training program, a digital nurse associate training program that we're hoping to commence August, September time this year. So that will support new nursing associates into general practice, and we'll give them a foundation level skills and knowledge that will include cervical cytology and IMS and VAX training as well.
I'll just launch the last polls then. So this next one is: are you any clearer on the role of a nursing associate now? Just launch that, and hopefully
you are.
Yeah.
Please.
And hopefully the poll will work this time.
So there are some errors again in the chat.
But the responses I can see are 100% yes, 26 responses. So yes, so people are now clearer. So thank you, Leslie. And then just the next one is if extra support was available, would this help with recruitment of nursing associates? So I'll just quickly launch that one.
I suppose that's really making reference to what Leslie was saying is in the pipeline, the offer that's in pipeline, really. If we can get that rolled out quickly, would that help with the recruitment? There is actually a question in the chat, actually, Leslie, from Tracy. Can a nurse associate attain further training for childhood IMS?
Yes, yeah, that's what we'll be hoping to do. Oh, for childhood immunisations, well, we'd give the training for the whole lot. They would still be working like a healthcare assistant for childhood immunisations presently because they can't work with a PGD.
So there is also a question about what's the rate of pay?
So
for newly qualified.
For newly qualified, it's band 5.
And Christine Russell has asked, what about those students who not long ago did the foundation course for TAPS?
TAPS. So there's some there are some universities looking at the moment at how we can get TAPS over to become nurse associates if they want to. There was an issue around whether they'd done an apprenticeship, and there was an issue around the level that they'd attained, the degree level they'd attained. So that's all being ironed out at the moment, and hopefully those that want to be on the register, obviously, because that's what they want to be, and extend their role a bit further, because unfortunately assistant practitioners cannot do cervical cytology and the like, so it is a bit of a disadvantage for them. So there's a couple of universities that we're in touch with at the moment and looking at how that can happen, so we can get back to those people that are interested in that. So Mike said, would that support include backfill for current HCAs? So to undertake the course, Mike, is that what you're talking about?
It was more of the question was in terms of support. So I was basically looking to sort of see how far and wide that support would extend.
Okay,
what
so
support actually include, basically.
Yeah, so the presently we have the healthcare support worker pilot ongoing. It's a digital pilot, so the nurse associate training, foundation training would be again digital, but it would be supported by a local training pod with nurses in it that will support the development and the skills and knowledge.
Right. Okay. So it's for the individual, not for the employer, in terms of the support.
The support, yeah. Yes,
Okay,
but
thanks.
but the training doesn't take your new nursing associate too far away from practice. The actual support of the nurse trainer will come into practice to support that. So it releases your nurses from actually training somebody and passing their competencies.
Well, thank you.
So in Leslie's previous slide, there was point of contact for your locality leads. You absolutely can reach out to them. You'll also have Leslie's contact details as well. Thank you very much, Leslie. So Lynn, I'm sorry, we are running a little bit behind time, but Lynn Marsland's joined us today because you did indicate that actually you would welcome some support around some HR issues. So I'm going to hand over to Lynn.
Hi, thanks, Kerry, and hello, everybody. I recognise a couple of names, but I probably haven't met the majority of you. So I've got a colleague with me here as well, Dominic Anderson. So the two of us are going to kind of start off the session. And then what I would very much like to do is to get a bit more understanding of what it is that you're looking for from these sessions. So I'll just very quickly, for those of you who don't know me, my name's Lynn, obviously, and I've been employed by the Primary Care Board through Tracy Vell and Janet Castrogiovanni to provide HR workforce type support across primary care wherever needed. My key focus has been on the enabling PCNs and federations and practices to employ additional staff, so the R's roles in particular, and also I've been working with Dominic on some of the health and well-being stuff that was launched last year. But basically I'm here in the nicest sense of the word to be used if there are any thoughts, comments, concerns, etc. that you might have about your staff right across primary care, that is. So Dominic, do you want to say a quick hello as well? Oh, you're on mute. You're still on mute. Yeah.
I know it's not responding very well today. Hi everybody, I'm Dominic. I'm the Health and Wellbeing Programme Manager for Greater Manchester, and just working with Lynn to bring in the wellbeing elements around this kind of development that we're bringing to you today.
Great, thank you. So I sent a few slides over, and I'm just hoping that either Rose or Dominic are going to be able to drive, because there's basically, I suppose, three sections to this first chat with you all. The first is to make you aware of some training and support that we would like to offer you with regards to some of the subjects that you have been talking about from an HR perspective. The second is for me to spend a bit of time getting to understand a little bit more about the kind of things that you want to know more about. And then the third element is just to talk to you about some of the plans that we've got for a single point of contact for you all across primary care when it comes to this very broad heading of workforce. So if we could just show those first slides, please, Rose, are you able to do that?
Yeah, that's fine. Yeah, bear with me.
I've got them, Rose, if you prefer me to share them.
No, it's okay. It's all good.
Great.
That okay? Can you see those?
Yes, thank you.
Okay.
Yeah. So so that's brilliant. So Dominic and I both work within a team now which is called Primary Care Excellence, and supporting the Primary Care Provider Board. So these are our logos that you will hopefully become a bit more familiar with. And it's quite a long-winded title, this, but it's something that I've been trialing in other areas, and it's loosely called Supporting Managers to Manage Attendance. So if we can flip onto the next slide, I'll just tell you a little bit about the background to this. Thanks, Rose. So as you know, not just here in GM, but certainly across the NHS in general, and particularly in primary care, there have been and continue to be high levels of sickness absence. We've seen things happening really since before COVID, and certainly COVID hasn't made things any easier for people. NHS England commissioned some work, mainly, I think, looking at hospital trusts, which is unfortunately fairly typical, but that's where they began their work. And what they were looking at was there anything that could be done by frontline managers to try and reduce the levels of high sickness absence? And for once, GM didn't win the highest, the area with the highest sickness absence levels. It was actually Cheshire and Mersey that beat us at the back end of last year there. It was very clear that this wasn't about policy and procedure. So it's not about how do I implement a sickness management a sickness absence policy, or any of the policies associated with that. This is about understanding what's going on with the people that work for you and with you in some of these particularly sticky issues, because quite a lot of the time, being off sick is actually masking what's really going on for someone. And certainly I've been around HR and workforce and OD for a very long time, and I've seen it happen, and as I'm sure some of you will have done as well, that there's a bit of an issue with a person, maybe their behaviour or a relationship at work, and the next thing they go off sick and they cite stress or anxiety. Now, I am not saying that they are not suffering from stress or anxiety, but actually there are things that we could maybe have spotted and anticipated that have caused this to happen. So being off sick does often mask what the real problem is, and it might even be a problem at home, as I think we've become more and more aware of since COVID. So the whole idea of the programme was that I would work with frontline managers to look at some of the skills and techniques that would enable you to spot and anticipate potential problems before the person goes off sick, or to enable you to bring somebody back to work more quickly and effectively, because even if you can't bring them back to work full time because of some sickness absence problem, you might get them back 2 or 3 days a week, for example, which is always going to help when you're trying to make sure that a service is being run. The programme was extremely well received in Cheshire and Mersey. I think the issue for NHS England was they were expecting some sort of miracle at the end of the programme to see the sickness absence rates drop drastically, and it's never going to do that. This is more about a cultural change, a different approach to managing your staff. So if we can move on to the next slide, please, Rose. Thanks. So when we started the work back end of last year with Dominic in looking at health and well-being resources to enable you to look after the health and well-being of your staff and also your own. I think it's very important to understand that it isn't just you here. But we thought we would put together a customised opportunity for practice managers across GM. It isn't about policy and procedure, as I've already said. It's not one of those, if this happens, you do that. You need to follow page 15 of the policy. If it goes wrong, this, that, and the other. It really is focusing on real issues and current situations. I'm sure the majority of you will have, I don't know, whether it's a bit of a niggle maybe about someone that you're working with, or some sickness absence that's happened that you can't quite put your finger on, but you would like to understand a bit more whether you could have done anything differently or next time maybe. But also it's about there's great benefits in this for thinking about yourself. So it isn't just about the people that you work with or who work for you, it's also about you. And it's about, as practice managers, I mean, some of you will have been managers, no doubt, for quite some time. You have a whole range of skills and techniques. This is another couple of skills and techniques, etc., for you to add to your management toolkit. So that's a bit about the offer, if we can move on. What the programme actually is all about is it's 2.5 hour sessions. Now, I think it's fair to say that we have funding for this, Dominic. So I'm not anticipating that people would have to pay for this programme, but Dominic will obviously point me in the right direction if I've got that wrong. These sessions work brilliantly face-to-face. However, the ones that I did for Cheshire and Mersey, we also did remote. So they worked well that way. So there's an option for you to do them in PCNs or in localities, or to do cross-section across GM, for example, and we could think about the logistics of that. But basically, it's about bringing a real issue or a potential issue to work on. With session 1, we look at some of the skills and techniques which enable you to spot problems, think about things a bit differently, and understand what potentially is going on in the background. And then you make a plan to enact some of those skills back in the workplace. So ideally, you'll be bringing with you a real situation. There's then a break of about a week, 2 weeks between the sessions, where you go away, get an opportunity to put it into practice, whether that's a real situation that you're trying to manage, or whether it's just the way that you work differently when it comes to interacting, having difficult conversations, etc. So you come back, which gives you the opportunity to think about how it went, what went well, what was the outcome. Is there anything else that you would like to build on or learn to do differently going forward? So that's what the programme entails. And then I think, Dominic, you wanted to talk about the next slide.
Yeah, so just looking at how the programme would wrap around with the health and wellbeing programme, and that could be signposting people to resources in Greater Manchester or nationally. It could be bringing external support, but also it could be what the programme can deliver as a follow-up if you've identified particular issues that you'd like support with. And one of those that's currently in development are some bite-sized resilience sessions. And I don't think resilience is a particularly good word to use, but I've used it because that's the language that's used in the research and evidence that back up some of these tools and techniques that would fit into the resilience sessions. But we could choose a more appropriate word that is less controversial, maybe. But some of those sessions could be looking at some of these different elements around psychological well-being, engagement and motivation, job satisfaction and work happiness, self-esteem and sense of control, sense of purpose and commitment to the team and organisation. So there are tools that exist that we can apply to all of those in an interactive session. And having all of those tools together would probably be about a 2-hour workshop, or we could break them down into much smaller ones, because I know time's a huge pressure on people. But it was just having an opportunity to say that the Health and Wellbeing Programme exists really to support the workforce, and we can be responsive in designing what is going to be useful in your particular context. So I'd be really interested to hear what you think about the support that you would find useful, and then I can continue to develop the opportunities on that basis. So I think that's the end actually, Rose, with just one more slide left with just some questions.
Yeah.
And getting your feedback.
Yeah, I don't think anything's gone in the chat. I have been trying to keep an eye on that, but really would just like to off the top of people's heads, is there any interest in hearing a bit more about that as a particular programme? What do you think? Yeah, sorry, I think is it Mike?
Yeah, hi there. It's just I suppose linked to whether it would be relevant really, because I use the Bradford score quite heavily when it relates to sickness, and at each stage there's sort of certain triggers, and a lot of it is to do with patterns. Is there anything related to that within these courses, or would it be just a different type of tool to use?
I guess it underpins a lot of what we would cover in that. I could certainly put reference into that, but I think that it's very much around the skills, techniques, looking at things slightly differently. What I was trying to do, I was looking through, I think there were 11 topics that were raised in your meetings about HR subjects that you would really like to cover. And when I've looked at them, so difficult conversations, performance management, disciplinary, managing up, all of those subjects, the particular tools that we would touch on this programme would really underpin a lot of that, and therefore, as I say, make a difference to managing sickness absence. For example, it's also very closely linked to performance management and disciplinary. So from a subject matter, you are touching quite a few of the topics that you've already said that you would be interested in doing it. But I could absolutely make the links to the Bradford. Mine's just gone blank. The whatever it's called. I do know.
Factor score, I think, is the overall. Yeah.
Thanks, Mike. Yes, I can make the link to that if you would find it useful. I'm just looking at some of the comments. Yeah, I mean, definitely it sounds like there would be quite an interest there. There's a point there that Wendy's made about new managers. I think you've absolutely cracked it there, because on the programme that I did in Cheshire and Mersey, I did some work with the Women's Hospital. They were very much involved in all of this. In fact, it was just after they'd had that awful bombing in the car park, if you remember rightly, and the sort of conversations that they were having to have with staff there were extremely difficult, not to say the least. But there was 4 newish managers. I think the person who'd been around the longest was about 7 or 8 months into post, and they were saying, oh, if only we'd had these skills and things on day one, what a difference it would have made to you. But also I was working with managers who had been around quite a bit, and you know that thing, you can't teach an old dog new tricks. You can, because a lot of this people kind of knew, they were aware of in the background, but didn't quite know how to voice it and then put it into action. So I think it would hit both spots. And now I'm looking at my watch because I'm very concerned that we're about to overrun time. And there was a couple of things that I wanted to talk to you about, but maybe we could do this differently, Kerry. What I had hoped to do this afternoon was to kind of find out from your list of HR topics. I don't think they're going to be policy related, because I'm assuming that you would have different policies and procedures to go through. So what are the generic things underneath that I could try and put together for you for these kind of half-hour spots going forward? But maybe we could do that via some sort of poll or something. I'm looking at Rose and Kerry here, after today's meeting.
Yeah, no, that'd be really and actually the comments in the chat, I'm really sorry, somebody's now mowing the lawn or something. The comments in the chat, Lynn, it seemed to be that it would be very much welcomed, either for existing practice managers, aspiring practice managers, but people certainly on that career pathway.
Absolutely. So I think what we'll do is we'll work. I can work putting some more detail on this, and I'm going to very, very, very quickly end by saying that what we're doing under the remit of primary care excellence, as part of support for everybody working across primary care, is we're putting together what will be a new website. And on that website, there will be a bit, a technical term, a page, whatever you want to call it, about our primary care workforce. So people who are working in primary care, which will be a single point of contact for everybody. If it's got anything to do with workforce, there'll be health and well-being under there. There'll be links to what's going on in GM. There'll be some stuff around basic job descriptions, contracts, model contracts. So you will have a single landing space, and then from that you might be directed onto something, or there'll probably be an inbox where you can ask questions, but that will be starting to go live from September. So hopefully you'll find that of use. I'll shut up, sorry to have overrun.
No, we were overrunning a little bit anyway, Lynn, so thank you. Thanks very much for that. I know we're losing some people now, and kind of as the meeting's coming to an end, just to remind you that there won't be a meeting in August, but we are absolutely really excited about the meeting that will go ahead on the 29th of September. It's really around how to stay productive and avoid fatigue in new ways of working. It's delivered by the really brilliant Rachel Morris. And so please do share the word about kind of attending that session. Rachel's done some podcasts for us, and they're absolutely excellent. And we will invite Lynn back to kind of offer that HR support. Maybe we'll refine what that looks like kind of going over the summer holidays. So I do hope that you get some time off, that you get to kind of bask in some sun when your feet are in a swimming pool, not as it's been this week. Do look after yourselves. If you need any help or support, please do come back to us. Thank you for coming today.